Hello, welcome everyone. Thank you for joining us this afternoon. We're just slowly watching the numbers trickle up. We've got about 80 registered today, so we know with sessions like these that people might trickle in as they're having their lunch and finishing previous meetings. Thank you for registering for our event, our Q&A with Professor Sir Michael Marmot. I'm just going to do a little bit of housekeeping before we get started, and then we will dive in. So just as a brief notice, the session today will be recorded. While you won't be on screen, we disabled video functions. It's just so you know, and that the recording will be circulated later. There will be an opportunity to submit any questions you have using the Q&A function, which you should be able to find on your menu bar at the top. There is a Q&A element, and it should have a little text box that says discussion. That's where you put your question in. So please feel free as the conversation is evolving today to submit your questions, and we'll try to field those. If you see a question you feel is particularly relevant to your work, upvote it, like it, because if we get lots of questions through, we'll try to prioritize those that get the most interest. There's also a chat function, which is separate, so please submit your questions in the Q&A function, but the chat function's there, and we should have pinned a post with the help of our amazing backroom assistants to point you to our HDRCs websites if you want to find out more about HDRCs and what we're doing in the region. So please have a look at the chat and the pinned post, and you can see it there. And finally, there will be a short survey at the end of today's Q&A. It's just a Microsoft form. It shouldn't take more than about 4 minutes. And we would love to hear from you. So this is our first regional event as a collection of HDRCs in the Southwest. And we would really value your thoughts about future events, opportunities, and how we can expand the reach of HDRCs. Okay, that is housekeeping covered. And so I'd like to introduce myself. I'm Brittany Strange. I'm the Program Manager for Somerset HDRC, Health Determinants Research Collaboration. That's a partnership between Somerset Council, the University of the West of England, University College London, and our VCFSE partners, Spark Somerset. And I'm joined today by Dr. Emily Taylor. Emily, would you like to introduce yourself as well?
Thanks, Brittany. I'm really pleased to be here. My name is Emily Taylor. I'm the Senior Research Support Officer for the Health Determinants Research Collaboration in Cornwall. And we're also a collaboration. We're collaborated with 3 universities of Falmouth, Plymouth and Exeter, and also with Cornwall Voluntary Sector Forum and working with communities. And yeah, pleased to be here. Thank you.
Thanks, Emily. And we're also joined today by Plymouth City Council and Plymouth HDRC. We think some of them might be dialing in. It's just a bit of notice they've had, as you can appreciate, there's pretty bad weather today, and they've had some flooding issues at their venue. And so Wi-Fi is a little bit patchy. If any of our Plymouth HDRC colleagues have been able to join us, welcome. We hope that you're warm and dry. But Plymouth HDRC is a partnership between Plymouth City Council, the University of Plymouth, and their VCFSE partner, POP, Plymouth Octopus. So with that said, we particularly would like to welcome our special guest. He is a professor of epidemiology at UCL. He's the founder and director of UCL's Institute of Health Equity, author of The Health Gap, and lead researcher of Fair Society Healthy Lives, or what we call in the public health biz, the Marmot Review. Professor Sir Michael Marmot is a leading voice in the UK and globally on health inequalities and the social determinants of health. And we're delighted to welcome him to today's Q&A, where we hope that we can explore the role of local research in addressing health inequalities. So welcome, Sir Michael.
Thank you.
Great to have you here. Are you happy for us to get started?
Please.
Great. Well, let me start with a pre-planned question. So I think one of the things that would be really useful to do is to talk a little bit about the Marmot Principles. As I understand it, I think the Southwest was the first Marmot region in the country. And not everybody might be aware of the Marmot Principles, what a Marmot area is, and what you're trying to achieve. So it would be great to just have a little bit of insight from you on those principles and what it means to be a Marmot area or region, and why you hope that by adoption of the Marmot Principles, it might lead to meaningful change.
Well, if I can give you just a little bit of background, and I promise not to take more than 40 minutes with the background. When I chaired the World Health Organization Commission on Social Determinants of Health, and we said this is a different way of doing health. You've got disease control, you've got primary health care, and now we said this is a different way of trying to improve health and reduce health inequalities. Action on the social determinants of health. Now, we produced a report for 193 member states, a bit complicated, and we tried to make a virtue of necessity, and we said it was very important for different jurisdictions to take our principles and adapt them to their context. I was thinking initially of countries, but we've got Marmot places. I'll come to that in just a moment. And Gordon Brown was the Prime Minister of the United Kingdom, and he commissioned me to do a strategic review of health inequalities to answer the question, how could we apply the findings and recommendations of the Global Commission to one country, England? We published that in 2010, and that Fair Society, Healthy Lives, the Marmot Review. That was February. In May, the Labour government lost the election. I'd like to think that there's no causal connection between my report and their losing the election, but who knows? And we had the Conservative-led coalition government. They produced a public health white paper saying it was the government's response to the Marmot Review, but in practice they had other priorities. So they clearly were not going to act on it. So now what? Do we sit on our hands? Well, Coventry said, we're not going to sit on our hands. We're going to take your recommendations and apply them at the city of Coventry. I hadn't thought of that. I thought countries would do it. But so there was a negative reason for Marmot places. If the national government isn't going to do it, then maybe local government, city government could do it. There's a positive reason. And Coventry illustrated this. They're much closer to the reality of people's lives. And the local councillors really, really care. If you're sitting in Westminster, you care, but you're not in touch every day with the reality of people's lives. And so there's a positive reason for acting locally. So Coventry took what were then my 6 principles and said, we will apply them. Give every child the best start in life, education, employment and working conditions. Number 4, having enough money to have a healthy life. 5, healthy and sustainable places in which to live and work, including housing. And number 6, taking a social determinants approach to prevention. So then I went to Greater Manchester, and Andy Burnham was the mayor. He had been Secretary of State for Health in the Labour government in 2010 when I delivered my review. And he said his biggest disappointment about losing office was he couldn't implement my review. He said, we'll do it in Greater Manchester. Then I went to Liverpool and met the Metro Mayor, Steve Rotherham, said, do you know what they're doing in Manchester? Then went to Newcastle, said, do you know what Liverpool and Manchester are doing? And on we went round the country. So we now have 60 Marmot places. To the original 6 principles, we've added 2, tackle racism, discrimination and their outcomes, and pursue environmental sustainability and health equity together. And these places have taken those principles on board. Local government, the voluntary and community sector, the health and care system, education, police, fire and rescue service, business. We've got them working together to apply these 8 principles. And working together, I slipped over that. That's different. That's saying we've got to have a joint approach to doing this. And that also means a culture shift. And that the purpose of what we do locally, these places are saying, is to create better health and well-being for everybody with greater health equity. And it's really inspiring.
Yeah, I mean, it's so fascinating to hear how you had the ambition using that global input to have a countrywide strategy, but how local systems stepped in where there was that political change to meet the need instead. And so it kind of leads me on nicely to the next question. And I guess it's about the role of research within that. I think what we found in our baseline study, Sir Michael, is that sometimes people can have this concept of research and evaluation that is stigmatized, that it's only for certain people and it's only for a certain sort of academic and that's it. And you'll know that what we're trying to do as health determinants research collaborations is to build that research capacity within local government and within communities. And with those who might not see themselves as quote unquote researchers. And so how can we change the narrative about who can be involved in research and the power of those local systems to really influence change?
Well, let me confess, I've changed. I was on the wrong side, quote unquote, of this divide. I was doing research funded by the Medical Research Council, by the US National Institutes of Health, the British Heart Foundation, and the like, Wellcome Trust. And this was PACA research. The aim was to publish peer-reviewed papers in the Lancet, the British Medical Journal, and so on. And I kind of looked down my nose at what I thought of as applied research. But I've changed. I think we need both. Let me give you a very practical example, very tangible. I was last week, I think, where are we? Yep, last week. I attended the Manchester City Council Health Scrutiny Committee. So it's quite interesting, I think, to think about research in this context. We drew on the best research evidence to elaborate the Marmot Principles, and we did the report for Greater Manchester. The City of Manchester took up our report, Build Back Fairer in Greater Manchester, and they said, we now will respond to your report with a 5-year plan to make Manchester fairer. We like your principle of proportionate universalism. And to give you one example, they presented an annual report at the committee last week. And I was intrigued at their approach to improving early child development, age 5. As you know, children eligible for free school meals, the poorer children, in general do worse than the average, the non-free school meals kids. So proportionate universalism says improve things for everybody, but work harder for those most at risk, most in need. Well, if you look at what had happened over the last year, the percent of children age 5 with a good level of development had improved across the board for everybody. Great. They've got the universalist part, but it had improved more for the non-poor kids, the non-FSM kids. Now, that may not get you a paper in the Lancet or the British Medical Journal, the BMJ, but it's terribly important. That's, people like me in a previous life might have looked down our noses and say, what's your hypothesis? What are you testing? New science, whatever. But this is research. It's using data to keep track of what we're doing, because we're all nice people here. We all want to do good things, but it doesn't mean that what we do is effective just because we're nice people. So we need to keep track. And there they are in a systematic way, collecting the data that reflects on what they're doing. When we did a review of structural racism, and I said to one of my colleagues, look, if a woman tells us that she experienced racism in the maternity services, that's not quite evidence, is it? And my colleague said, yeah, that's evidence. That's evidence. You don't have to count up. If a woman experienced racism, she experienced racism. That's evidence too. So I've come off the straight and narrow of what constitutes research and evidence to have a much broader view about the importance of involving people who know things. It doesn't mean everybody's point of view is equally valid, but we need to listen. We need to keep our critical faculties. But I'm all in favor of involving a broader range of people, including people like the woman who says, I experienced racism in the maternity service. That's evidence.
Yeah, thank you. And I think really, really helpful to hear about how you started in one place, but actually recognizing that change that's taken place over time. I know when you were last in Somerset, we were talking about how you are mostly a quant guy, you're a quantitative guy, but actually how over time you're really seeing that people's stories are evidence and it's useful data and it's meaningful and it's important. I'm going to hand over to Emily now to ask next questions. I can see some are coming through from the chat as well, Emily. So it's up to you about whether we go from a pre-planned question or pivot to some of the ones that have been submitted.
Thank you so much. Yeah, and very refreshing to hear about those different ways of thinking about evidence and what evidence means. So I think actually there's one in the chat sort of responding to that idea around proportionate universalism, and it says around struggles to balance the ideas of proportionate universalism and universal solutions, with the understanding that different communities might have different health priorities and even define health differently. Be really interested to hear thoughts on balancing broad public health evidence to local context priorities.
Well, let's think about the National Health Service for a moment. It's a universal service, available, free at the point of use, so it's available to everybody. Most of us would like to see it not undermined by contracting out. Most of us, I think, appreciate its value, but we don't all get equal care. If you've got diabetes and peripheral vascular disease and ocular complications and renal complications and maybe cardiac complications, you get a lot more care than somebody who doesn't have any of those things. I don't feel bad in any way at all if somebody gets much more care from the healthcare system than I do. So we've got a universal system with effort proportionate to need, the whole principle of proportionate universalism. Now, I'd like to define needs socially, not just clinically, but the idea of a universal system with effort proportionate to need. I mean, in education, what we've done it the other way. We've got a universal system with effort inversely proportionate to need. The most privileged can buy their way out of the universal system to gain even more privilege. So we've done it the other way. Ideally, in Finland, they have no private education. They have one system. They would claim, and they've claimed to me, that they have effort proportionate to need. They recognize the needy. When I visited a Finnish school, they had pupils from upper middle class, as we might call it, middle class and working class. And the head teacher saw as an important part of her role, the kids who were more needy got more effort and attention, but all being part of a universal system. So that's the challenge. I can point to good examples of universal approaches. I can point to good examples of targeted approaches. I can point to fewer examples of where proportionate universalism has been put into practice. But the one that I started with from Manchester, in a way, looking at early child development, they've got the principle. And what the data show is they need to work harder to get the principle working.
Thank you. Yeah, they're really great to sort of hear about those different perspectives on it, and that there are some really good examples out there. This one kind of links into one we had around how to prioritize when research can sometimes end up as being a nice to have, and when there's sort of funding challenges, but also this question relates around like the political challenges. So it's asked about, in the field of health policy analysis and interventions, we always consider the opportunity window when policy aligns with political will and needs, problems and solutions. How can regional research align with the temporary political will of interim governments in a context where governments are constantly changing?
Yeah, it's interesting. I haven't really consciously thought, how do we change what we do in relation to political will? I think I've spent a lot more time thinking about, how do we change political will? We know what needs to be done. We've got people, again, in Manchester, they talk about lived experience. We've got people telling us what needs to be done to improve their lives. And if the political will isn't addressing those issues, then we have to change the political will, not change what we do. And if the person who asked me that question tells me that I'm being naive, I plead guilty as charged. Yep, I'm all in favor of naivete. After all, we are trying to do the good thing, aren't we? We're trying to do the right thing. We're trying to improve health of everybody and improve health of the most disadvantaged more, to bring them up to a higher level. What could be more important than that? And if the political will at the moment isn't supporting that, then we've got to change it.
Thank you. That's really, yes, again, refreshing advice to sort of flip it on its head and ask ourselves, actually, is it right to follow, or do we actually have a role here in changing that? I wonder, from your experience, do you have any examples of when, if those sort of, even if they're sort of micro changes to political will, of things that have been successful in changing that?
Yeah, I've got 60 examples, and they're called Marmot communities, all around the country, England, Wales, and Scotland. And now we're going to have our first Marmot community in the Republic of Ireland, in Limerick, at the Midwest of Ireland. And it was local government saying, we're going to do this. It's important. It sometimes came from the chief executive of local government, sometimes from the health and care system. But it was saying, whatever the national political will is, We're going to do it in our domain, be it a region like Greater Manchester or Cheshire and Merseyside, or the North East Combined Authority, be it a region, be it a city like the City of Manchester. We're about to kick off work in Birmingham, or a region like the South West region. We're going to do things differently. If the political will nationally isn't supportive, then we'll have to do the best we can in that context. So yeah, I've got 60 good examples.
Thank you. Great answer. And I suppose, yeah, the having the map, the sort of roadmap provided with those principles to follow and think about how we can engage those and introduce those in our areas is a really great tool for that. Brittany, I'll hand back to you for the next question.
Yeah, I was just listening to, I think it's such a great example, Sir Michael, of seeing local systems go, okay, you know, nationally, the government isn't doing this, but actually we're willing to do this, and how that might further shape the narrative. What would, again, when we last spoke, I think that there is work that you're doing, as far as I understand, to really get to grips with what it means to be a Marmot area or Marmot region. And so I'm wondering, have there been any repeat pitfalls or barriers or opportunities in areas when it comes to promoting the Marmot Principles and messaging around health inequalities that we could collectively either avoid or maybe learn from?
So one major barrier, and I think I talked about this with you when I visited Somerset, and I've certainly talked about it in the region before. The government that was in place after 2010 declared war on local government. The funding to local government from central government went down by 59% over the decade after 2010. And we plotted life expectancy of every local authority in England in 2010-12, and then looked at the subsequent reduction in local government spending power up to 2020. The shorter the life expectancy in 2010-12, the steeper the subsequent reduction in local government spending power up to 2020. You look at this and you think, this was a national policy designed to make sick areas sicker. What on earth were they doing? It's not proportionate universalism. It's effort inversely proportionate to need. So this is a major barrier. But Liverpool, for example, didn't say we've had 42% cut to our funding, there's nothing we can do. They said, come and help us. We want to do the best we can with the settlement that we have. And as I said, we did a report for Cheshire and Merseyside region. And then Liverpool, just earlier this year, this spring, launched as a Marmot city. So the barriers are extreme. The reduction in funding to local government, they're brutal, the cuts, but they've been doing it. One other potential barrier, but that hasn't loomed so large, is when people talk about health, they usually talk about health care. And so they think if you're talking about inequalities in health, you're talking about inequalities in access to health care. Such inequalities are important, but we're talking about inequalities in the social conditions that lead to ill health. So at times there can be a barrier to overcoming that, because particularly for people in the health and care system, they say, we know how to do our job, but are you asking us to do a different job, addressing the social determinants of health? Well, yeah, in a way we are. We're asking you to work in partnership with others who are addressing these broader issues. So the finances are a barrier. But the resistance from the health and care system is much less than it used to be, much less. I mean, the medical royal colleges have been great supporters of late, which used not to be the case in the past. The Royal College of Physicians, the Royal College of Pediatrics and Child Health, Royal College of Psychiatrists, the Royal College of General Practitioners, the obstetricians and gynecologists. We've worked with all of them, and and the Faculty of Public Health, of course. They've been great supporters. So I'm seeing a sea change, the opposition from clinicians saying, oh, this is public health, this is second-rate stuff, we don't want to do it, to saying, we see the consequences of social inequalities for the health of our patients, and we recognize we've got to work on it. So you can tell that I tend to be upbeat, not ground down by the difficulties.
Yes, I always appreciate your optimism. I think it's important in the work that we do. I have a follow-up question to that, really. What do you think, again, I feel like it's something we've talked about a little bit, but what do you think has led to that sea change? So you're saying that where that wasn't embraced previously in certain more clinical settings, that now people are starting to take notice. So was that COVID and some of the very glaring examples that came out of COVID, or were there other things that you feel that happened that enabled that sea change that we can learn from?
Yeah, it's a good question. And one of the problems of learning from experience is if you don't understand your experience, you can't really learn the lesson properly. I'm not quite sure why there was such a sea change. Retirement might be part of it. An older generation of the great doctors retired, and a younger generation who are more open to these ideas. I mean, when I don't do it so much now, but when I used to teach first-year medical students at UCL, now these kids are brilliant. To get into a medical school like UCL, you've got to be high performing. I remember a medical student from Birmingham said, at my GCSEs, I only got 5 A stars and 5 A's, so I didn't apply to UCL. So we're talking about the cream here, and I'd ask them, what are you planning to do? Half would say primary care. They weren't saying molecular biology, neurosurgery. I mean, some are. And of course, one of the strengths of a place like UCL is we've got fantastic neuroscience and molecular biology and so on. But these brilliant young people, really high-performing young people, had a different approach to the world. They saw their role in medicine as different. And I'd like to think that they educated some of their teachers. They helped change attitudes. And so the attitudes are really different. The kind of thing that I do, when I started doing it a generation or more ago, there was a lot of resistance to it, much less now.
Yeah, that's really interesting, and interesting maybe to reflect. I'll reflect on that later, but what has changed generationally over time that has led to some of that thinking in the younger generation. I wanted to move on a little bit because you've touched on this a bit around partnership work and collaboration, and you've talked about your own kind of shift from seeing research a certain way to seeing it quite differently now. And so we have attendees here today from across the South West and some from local councils, but some from healthcare organizations or VCFSE organizations. And I guess I want to explore, I think there's this challenge in going, yes, we want really robust and rigorous data and evidence to support research questions and the work that we're doing, but we don't want there to be an imbalance of power in the voices that are given in those contexts. We want them, we want people to have an equal part. So what role do partnerships play between local authorities, community organizations, and healthcare providers in strengthening research capacity?
I mean, I think that the improvement here is patchy, but recognizing that we should not be talking. I mean, if you or I needed neurosurgery, we'd like to think that the neurosurgeon was trained to the nth degree, and was brilliant and well-trained and so on. That doesn't mean that the neurosurgeon should dominate everything that happens in the healthcare system. We like our neurosurgeon to be, absolutely brilliant, top of the line, and that she'd be better than anybody else at doing the neurosurgery. But whereas in the past, we'd say the neurosurgeon, the cardiac surgeon should be brilliant, and they should dominate the whole hierarchy. Everything should be subservient to them. I think we're changing and realizing people have different roles. And the same, the professor doing brilliant research. I'm all in favor of professors doing brilliant research. We need elite universities doing elite research. I'm all in favor of it. But that shouldn't happen to the exclusion of the kind of different approach that you're talking about, to recognizing the value of what people do. I mean, I'm just bowled over by watching committed people involved in delivering services under extremely difficult circumstances and what they do. And I think it's wonderful. And if we can encourage people involved in that to have a kind of analytical framework, to be asking the question, am I doing this in the best way I could? Is this having the impact I think it should? I mean, that's kind of research, isn't it? To be asking the question of what works, how do we improve understanding? And that can be much more democratized than it has been in the past.
Yeah, I agree. And I think it's about realizing, as you say, the assets that all parts bring. So in the case of what you're saying, HDRCs can provide some of that research capacity and upskilling people in some of those things that they might not have been exposed to, about better evaluation and better evidence. But even when you were talking about not necessarily being able to pin down what caused that sea change, sometimes I wonder, is it our communities, the advocates within our communities who are those voices to healthcare professionals who might not have as much proximity to the social determinants in the same way, who are being those advocates that are leading to that kind of like medical sea change as well. So I think it's important. All parts are important. And it's about what we can offer one another in moving the needle, moving things forward, I think.
And I mean, I know that, I talked about Coventry. It was funded as an HDRC in the first round. And I made several visits to Coventry. And what was wonderful to see was the, dare I use the word, joy in the room, the enthusiasm of people involved, because you could say, as a researcher, you're supposed to be dispassionate. You're seeking the truth, and whichever way it comes out is important. I've never met a researcher like that. We have our preconceptions, we have our hypotheses, we have our ideas. Now, if we stick to our ideas despite the evidence, that's terrible. Then we're not doing research at all because we might be wrong. But so having people who are committed to delivering services, to improving conditions for children, for young people, for working mums and the like, ask the question, could I be doing this better? Is there more I could understand about how I do what I do? That seems to me both good for further understanding the research enterprise and good for the practices.
Yeah, absolutely. Thank you. Emily, I'm going to hand back to you.
Thank you. Yeah, and just I think I'll definitely take away some of this really thoughtful and that those different perspectives so important to bring in, and love the idea of the importance of joy in the work as well, and those so the less sort of the emotional sides that we can bring to it as well. I was just thinking, maybe sort of following on from this sea change and that sort of change in attitudinal trends. I wondered maybe about like data and evidence trends and what emerging trends in public health research you think maybe that local systems should be paying attention to that you can see going forwards.
Well, the first thing to say in response to your question is the UK is doing really badly in terms of health. Life expectancy improvement slowed dramatically after 2010 and then declined. Life expectancy declined in the first 3 years of the pandemic, 2020, 21, 22. Inequalities in health got bigger, and health for the poorest people declined, or life expectancy for the poorest declined, and self-reported health got worse. So we're doing really badly, given that we used to think things would get better all the time. And they're not getting better. They're actually getting worse unless you're in London in a privileged group. And even then, you'd be better off to be in a lot of other countries from the point of view of health improvement. So that's the trend we're seeing, and it's a major challenge. A second thing we need to understand, income inequality went up dramatically in the 1980s. And then the rise in income inequality leveled off. So since the global financial crisis, income inequality hasn't increased greatly, but two things have happened. One is the 1% at the top have drawn away from the middle. The middle is starting to look more like the bottom 10%. And linked to that, we've seen a huge growth in wealth inequality. As wealth has accumulated, then the wealth holders, the rich, have got really rich. And the gap, so the relative distribution of wealth may not have changed much, but the absolute numbers of pounds that rich people have compared to people in the middle has increased enormously. The gap's huge. And related to what I said a moment ago about the middles looking increasingly like the poor, this major challenge that we are, to put it crudely, a poor country with some rich people. And we really need to change that. and it comes back to your earlier question about political will. If there's no political will to change it, we've got to stand up and be counted. We can't have a poor country with some rich people. There's a lot of money sloshing about, but if it's all sloshing about in some tiny number of bank accounts, and as Piketty pointed out, the return to capital is greater than the return to income. So if you have assets, if you own a factory, if you own housing, property, and the like, the money you get sleeping at night is greater than the rise in income from people who work 40 hours a week or 37 hours a week. So this unearned income keeps growing and earned income doesn't. And that sets the context for what we're trying to do. And we need to change that. How can you have an economy and society that runs in the interest of the top 1%? It's anti-democratic. And you don't have to be a socialist to say we'd like the other 99% to enjoy some of this. And so I'm talking economic, social, political, but that's a major challenge for public health. And what we're doing, but I've not said for one moment that we shouldn't have 60 Marmot places until we can change our political economy. By all means, let's see what we can do in the current climate to improve the social determinants of health.
Thank you. Yeah, it's so important to recognise that things aren't going well, but not to take that as sort of a point of, oh, well, give up then. It's actually, actually this is the call to action and this is what we can do something about. Thank you. I'm aware we're coming up to sort of 10 minutes left. I haven't seen any more questions in the Q&A, but I hope I'm not missing any. Please do feel free to add any further. Brittany, should I hand back to you?
Yeah, I think we'll start to wrap up, I think, Michael. I mean, you've covered a lot of ground. I think what's difficult is, I think maybe what a lot of people might ask is, where do we start? So in our cases in Plymouth, in Cornwall, and Somerset, we have health determinants research collaborations which are in place to build this research capacity. Great. There will be other local authorities who've joined us today. Welcome. We're really glad you're here, who don't have an HDRC, but who are really keen to do more with their communities, with VCFSE partners, with healthcare partners, to think, how do we really do exactly what you're saying? Take these local contexts and make a real difference. And I'm just wondering if you had any, it's very broad, but if you had any kind of recommendation about, like, how do you get started where it's so big, isn't it? Like what we're trying to do in terms of tackling health inequalities, addressing those unfair differences. For those people who maybe don't have those resources, how do they get started, or what should they be thinking about most?
Well, so the question, when the HDRCs got started, the question in my mind was, can you answer the question of which parts of the Marmot Principles work, under what conditions? Now, that's a very broad question. But if you said, look, we've got these 8 principles on which we're trying to act, and I'm particularly interested in improving housing. Could I show that by taking some action to make housing quality better, warm homes, children's outcomes get better? Children have improved mental health. They do better in school. So what I'm starting with, we've got this huge problem of social and economic inequalities and 8 principles, and it all sounds huge. let's take a piece of it that you have a particular interest, not you, but, you know, the person we're talking about, that mythical person, has a particular interest in, and see what's needed to answer it. And what's interesting, Legal and General, we're working with, they've put £2 million into funding local activities on social determinants of health. They funded 43 projects around the country, and they've also put £1 million into the Northeast. And these projects, any one of them could sound like a research agenda. And they're all tangible, they're potentially manageable, and they're very close, you know, to the ground where people are. I mean, any one of them could be a project for research. So, in other words, these are, you know, whether it's teaching cooking skills to immigrant women, whether getting kids involved in exercise or art classes, or, you know, you think of a thing, and this is in one of those 43 projects. And they're all susceptible, potentially, to asking the question, are we making a difference? And they're not on the big thing, are we reducing inequalities in life expectancy? But they're practical, important, tangible. And that's where I'd start.
Thank you. I don't know if we've just lost Brittany.
Yeah, I think we've lost Brittany.
We do have one more question in the chat that's come through. So whether we can, this might be quite a quick response then, but it asks about, I'm really interested to hear your thoughts on how medical professionals can use their improved knowledge to modify their practice to influence public health. Currently, frontline professionals are relying on us to deliver on improving the wider determinants of health, so they're able to focus on using their skill sets rather than managing social conditions on top of delivering medical care. We as medical professionals are great advocates for public health, as we can see how vital it is in terms of people's ability to benefit from healthcare. But in clinical roles without supportive social infrastructure, it is very challenging to create meaningful change in public health.
Yeah, it's a very important question. You know, I'm convinced by everything you're saying, but what do you want me to do? You know, it's a very important question. And I mean, a good clinician will already recognize how the social conditions that their patient comes from is influencing their health. They're very aware of that. As the questioner says, yeah, I'm aware of it, but I may not be able to do anything about it. So then the question is, well, can you work with the people who can? I mean, for example, in UCLH hospital, there's a group that work with rough sleepers. So they say to the clinicians, you may not be able to deal with rough sleeping, but don't just sling your patient back out onto the street after you've treated them. Let us work with trying to get them a bed and a roof over their heads. And social prescribing has a lot of that in mind. How can we deal with the issues that are impacting on our patients' lives and hence their health? So the first, as coming from the questioner, is being aware of it. Great. And then the second is having systems that you can call on that are able to work with these issues. Welcome back, Brittany.
A big gust of wind took my power out momentarily. So very sorry about that. Perfect timing. But great. Did we cover Laura's question? I'm sorry to have missed it.
Yeah, I think we did. So I guess we
Brilliantly
just...
succinct as well. Thank you on the timing.
Yeah, perfect timing. Thank you for being flexible, Michael. It's a bad weather day. Like I said, our Plymouth HDRC colleagues have been struggling with it, and it appears to have hit here as well. But it's been a pleasure to have you with us, and to think more about the realities of applying the Marmot Principles to tackle health inequalities through local research. And refreshing to know that you recognize the real challenges we face, but whenever we meet and talk, your answers always laced with hope and optimism. And I think the thing that I always take away is that all of us have a part. You know, it's so easy to get into a pattern where we step back and we're reacting to what's coming at us all the time, particularly where services have been reduced and cut. But actually, all of us can take a step and take a part in addressing these really important social issues that are having such a big impact on our communities. So lots to think about and take away.